Alrighty. Okay. So I know that Doug will not be here today. Melissa will not, and Beverly will be about a half hour late.
So do you want me to do roll with the rest of us here?
Yeah, that sounds great. Thank you.
All right. So Pam Reese,
Here.
Rhonda Johnson,
Here.
Doug not here, Melissa Schiffel,
Not here.
Lisa Brockman,
Here.
Jennifer Blau,
Here.
Senator Yuko, Diane Pakonka, and Beverly Robert, you said would be late. All right.
Yep.
And Tessie. All right.
Well, we should approve our minutes. Correct, Catherine?
Correct. And do I have a motion to approve the minutes as submitted?
Motion to approve minutes.
Lisa, second?
Yes.
I heard a second there, right?
I approve. This is Pam.
Okay. All right. Any discussion about those, or can I have a full vote on approval as submitted? I'm seeing nodding heads. All right. All nodding heads. So they are approved as submitted.
Perfect. Okay, so today we're just going to recap some of the work that we have in place. So Melissa had sent out the online survey that she had created for caregivers. And then I just resent it probably just 5 minutes prior to this call. And so just want to get a forum on approval of that online survey if possible, so we can get that out there.
Were there changes made per the back and forth discussion that we had?
So there was the to approve caretaker to caregiver, and that's a good question. I will have to follow up with Melissa to the others.
One, I think it'd be really helpful if she numbered these questions.
Okay.
And my challenge with it is the first number of questions. Again, they're not numbered. So let me see, 1, 2, 3, 4, 5, 6, 7, 8 questions. Speak to the person who could be both the individual who has been diagnosed or to their caregiver. It could go to either one of them. Mm-hmm. Then it moves into definitely what type of care is your loved one receiving?
Right.
So if I were the person filling this out as an individual with dementia, early diagnosis, then the next two questions don't make sense, but what would be helpful or useful to you in preparing a plan? What kind of a plan? A care plan, could we define that in the question ahead of it? Because the question ahead of it says, have you developed a plan for your one for care? So let's call that a care plan. And then what would be helpful in preparing a care plan?
Right.
And then it goes back to, well, it could be me with dementia or my loved one. So I just felt like
could make word it differently to go to either.
Right.
Okay. Anything else? Okay. So then I will submit those questions to Melissa and then have her resend it out. And then
this is Tessie. Do we want maybe one more very broad, open-ended question just as the experience committee? You know, what information do you wish you would have received in the beginning?
Good
Right,
idea.
and maybe that can help us
I like it.
kind of form that experience. It's going to be a beast to try and wrangle all those answers, but I think it'll be really good information.
Mhm.
You know, I think we ask a lot of particular questions about paths and treatments, but maybe just one very open-ended one to capture those
I like
thoughts.
it. Good idea. Thank you. Okay. Anything else? So I will submit these to Melissa, have her resend out, and then Tessie, can we all approve it with email?
Absolutely. Yep, on email. And then is it something that you would like to send out to the full task force ahead of the meeting on the 24th? Or do you want to just give them a little time to complete it during that meeting too? We could even do that.
Yeah. What do you all think? Should we send it to the entire task force?
I would. I think there's so much overlap in the topics that we have that I think they might be interested in some of the questions that we have on here. They may also be interested in adding their own question, which you know, would allow caregivers and people living with the disease to only answer one survey rather than potentially get hit with a couple.
Okay. All right. So then perhaps I can have Melissa do that. We can do that this week or by the end of the week, hopefully.
Pam, this is Diane. Quick question.
Yes, ma'am.
I saw an email from you this morning about checking the survey. When I
Yes.
took a look, it looked to me the same as the last one, though honestly I didn't fish the last one out. So I'm
Yes.
wondering whether there were changes on this one and I should really go back and take another look.
No, Diane,
Okay.
you were talking right before you joined that some of the suggestions we have to ensure get on this new survey.
Gotcha.
And so that's what we'll ensure, and then we'll send it back out to everyone.
Terrific. Thank you. Sorry
You're-
about that.
No, you're fine. Okay, moving on. Catherine and I have gone back and forth a little bit about setting up provider narratives, interviews, and Catherine is doing a great deal in selection and also in helping coordinate for these providers, and just wanted to talk about where we are with that.
So I have interviews scheduled using the timing that you provided, Pam.
Yeah.
I've interviews scheduled for nursing homes, for assisted living, memory support, hospice, and home care. So, Tessie, I'm going to need your help. I don't know if these are required to be public because they're 2+ an individual, but if we're going to have them be on a Teams platform, I'll need for you to send the invitations out.
Okay.
And Pam, I passed along your questions to folks, so they are prepared, and I believe we we need to have individuals ready to be the interviewees of these organizations.
Yes. And so I'm planning to sit in and do that on these calls, but would love if anyone else would also like to do it. And there will be, and Catherine, you'll be sending out the schedule, or we'll have it complete so everyone can see the time frames.
Yep.
So these are just quick calls with the individuals that Catherine mentioned. So there's going to be a call with the nursing home provider, the assisted living provider, hospice, home care. And is memory care separate, or will that be along with the AL?
It'll be along with the AL, although sometimes it's along with the NIF. But the interview that I have set up for you Actually, it's serving both.
Got it. And so I submitted some various days and times. And I will, once those dates and times come out, which I think it would begin the end of this week
Correct.
through next week, just because of time, just to hopefully get it done before Memorial Day. And I also just sent Catherine a list of questions. I will send that out to all of you as well for you to see, and they're basic, right? What are your barriers? What are you doing well? What would you like to see improved? Just those questions of, hey, tell me best practice, but also what could you use to enhance your services? And so I'm kind of seeing that with all of these entities just to get their input. But I will send all that out to all of you this afternoon. And then once we get the dates and times solidified, that'll come to you as well. Love for any of you to join in on this, to listen and to participate. So that would be great. Are there any questions about that? Okay.
I don't know if it would be helpful for folks to know who it is that we have set up, but the example, not example, but the hospice that we're going to be interviewing is Hospice of the Western Reserve.
Yes.
They've put together a regional dementia program and have worked with Dementia Friends, which is another group that I think would be helpful for this.
That is awesome.
To make sure that there are best practices for end-of-life dementia care in the nursing and assisted living facilities that they're working with. And the AL support is going to be, or the AL program is Kendall at Oberlin, and they've done a dementia program that is without walls or secure unit.
I like it.
It's required an incredible amount of education of their residents as well as staff. And it's a very interesting story. And then Altman will be doing the home care. And I'm nearly finalized on the nursing home piece.
Thank you so much for pulling this together. Perfect. Does anyone have any comments on that or any suggestions? We are moving right along here. So there's still several things on our task that we will have to talk further about. For instance, how the government adopts policy, quality measures, some of these different items. And I'm hoping that some of the clinical aspects, for instance, the quality measures, enhancing services, activities, that some of that can come out of these narratives or these interviews that will guide us and help us a little bit with some of those answers. But just something to be thinking about right now is obtaining further information about some of that. I also have been unable to connect with the Hospital Association and the first responders. I've reached out, I've not really heard back. So if anyone knows of how we can do that, that would take care of those providers.
I can reach out to the Ohio Hospital Association. I have a good relationship with at least their communications director, and that's always a great place to start, right? And then you can always connect with the appropriate person beyond that. So let me reach out to John Palmer at OHA, and I'll see how we can connect with someone there.
Thank you, Tessie.
You're welcome.
And then we still have those first responders, the police, EMS. I'm at a loss a little bit myself. Who could we ask to help us with that? Do we know of anyone?
There are associations for them. And there's also medical director. So I'm wondering if maybe we find the medical director connection there. And then we can go from there.
So I
We can talk with the Department of Public Safety Division of EMS.
Thank you.
The other thing, I'll be happy to ask Trey Addison, who is also on the task force, works for the Alzheimer's Association. The piece of legislation out there for first responders. I'm sure that they have had a fair number of advocates working for that. So, I'd be happy to see if there's any lead in that way as well.
Thank you so much. Okay, we are moving forward here. Jennifer, in like 10 minutes, we have our guest joining us today. But you also sent out Florida's Project Vital, which I don't know if everyone had an opportunity to look at it. And it's about their connections between individuals living with dementia, providing patient-centered engagement. It's just a really good program.
When was that sent?
Or did you just send it to me, Jennifer, or did you send it to all?
Thought I sent it to everyone. Maybe I didn't. It was probably a couple of weeks ago.
Yeah.
I'll find it and send it out.
Yeah. So I apologize for that. I was making an assumption everyone got it, but maybe not. But I would encourage everyone to read it. Perhaps it's something that would be helpful to us and some of our recommendations. But it's a different type of programming. And so I guess I'll just let everyone read it and then comment on what you feel about it.
The reason I sent that out was because the Alzheimer's Association is using that tool right now, that vehicle, to help educate primary care physicians and others within their staff, or even long-term care units, et cetera, to really create a foundation of learning around dementia for a system, and then help that system look at how they conduct their business, their practice, and see if they want to make any changes as a result of what they've learned. So when Lindsay joins us here in a little bit, Lindsay is representing Lake Health. Lake Health has been doing something similar to what's going on in Florida, just for their own hospital system here in Ohio. And in the course of educating their staff, I think this is now maybe the third time that they will be participating in a Project Echo. I forget what they call it, cohort maybe is how they refer to it. They've now started to identify a number of things that they could do differently in their practice. So anyway, the Alzheimer's Association is really looking at this as being a vehicle that we can use to provide that education here in Ohio. Further, if I'm not mistaken, and Lindsay may be able to talk to this, or I'll have to follow up after, they have recently started a Project Echo for long-term care facilities specific to dementia. So the original premise of Project Echo for Alzheimer's was for primary care physicians, and now my understanding is that they've started to expand that to long-term care facilities. Is everyone on the call familiar with what Project Echo is as a tool?
No.
No. Okay. Project Echo is a virtual platform that connects primary care professionals, mostly with specialists in a particular field. The specialists provide education, and then they have case studies, which are presented by the primary care facilities. And then they evaluate and talk about the treatment plan for those case studies. And it's a way for primary care physicians to build their own education amongst themselves and their staff, and also get some further advice, if you will, on how to handle their cases. Project ECHO was started, I believe I have this correct, out of the University of New Mexico, and it was, I think it was started for hepatitis, actually. Does anybody know that for a fact? So that was the model, and they have since, Project ECHO has built up a number of practices, including now Alzheimer's, and in the Alzheimer's one, it's a 12 session commitment for a primary care practice to go through. Those 12 sessions each have an element of education, maybe 10 minutes or so of education, and then they handle 1 to 2 case reviews for the remainder of that 1 hour time.
And in COVID, this is Catherine, in COVID, they expanded into the long-term care space, and the all teach, all learn concept of Project ECHO has been particularly impactful, I think, in the infection control side for long-term care providers. There is an extensive participation by Ohio's nursing homes in the Project ECHO program. And actually there was remuneration that a facility would receive if they had a staff commitment to attend a defined number of the Project ECHO courses, and with a defined number of their staff as well.
Mm.
Yeah, Catherine, I was going to mention the same thing. So I don't know, maybe that could be one of the recommendations that we have, that if we feel like that's a program that would benefit long-term care communities in Ohio, many of us have had experience with the ECHO program from a COVID standpoint. And there is as long as you have X number of employees participate for X number of the 15 weeks, then you receive some reimbursement at the end of it. In addition, the long-term care, Ohio Long-Term Care Association then took it a step further and even made it so that continuing education credits could be earned in participating in these weekly sessions as well. So maybe if we sort of looked at it.
And Leading Edge Ohio did the same. We partnered in order to provide CEs.
Wonderful.
Yeah.
Yeah, I think you get buy-in from people because they're getting a benefit even outside of the education.
Is there anything like this for home caregivers?
Not that I'm aware of.
Yeah, I don't know.
Okay.
I think Lindsay joined us.
I think so. Lindsay, are you ready and available?
Hi, yes. I am here. I am ready whenever you guys are. I want to apologize for how dark it is on my screen. I'm out a few light bulbs currently and have yet to replace them. So I'm not normally so shadowy in here. But anyway, thank you so much for giving me a chance to come and talk with you all.
Great. Well, Lindsay,
maybe others can see you, but I'm not having any camera from you.
No camera at all?
No.
No, neither.
So you guys thought I was joking around when I said it's shaky. Hold on, I thought. Let's try this again.
There we
shall
go.
we?
There we go.
You know.
well, welcome, Liz. For everyone else on our call, let me introduce Lindsay Cooper. Lindsay works with Lake Health as a gero nurse practitioner. Do I have that right? You joined Lake Health 5 years ago with the goal of developing and growing a successful house calls program to service the elderly and homebound population of Lake County in Northeast Ohio. She is now overseeing a practice group that includes 4 service lines and continues to practice clinically in the community. She has a special interest in geriatric syndromes and palliative care. Prior to coming to Lake Health here in Ohio, she was in Massachusetts. She received her BS from Boston University in microbiology and moved to Cleveland in 2007. Where she completed her MN and MSN at Case Western. Lindsay has 3 dogs and 2 children, so a full house. Mm-hmm. And when not caring for any of her residents, she can be found gardening, hiking, or practicing yoga. So welcome, Lindsay. I do want to add that Lindsay at Lake Health is also overseeing the Project Echo initiative for educating and following up with quality improvements for the care that their patients receive. So Lindsay, I'm going to turn things over to you, and when you're ready to open it up for questions, just let us know.
Okay. So thank you so much, Jennifer. I appreciate your introduction and the invitation to come speak with you all. I actually, my connection with the Alzheimer's Association began formally, my formal connection began about 3 years ago when I was invited to participate in the professional advisory board. So I've been doing that for the past year. It's been largely remote, but prior to that, we were all meeting in our local chapter and advising. Our primary role was managing the annual Foley presentation, which I'm not sure where you folks are all located, but if anybody's in Northeast Ohio, perhaps you're familiar with it. It's a lecture that's done in the fall, and there's normally it's normally the audience, the targeted audience is professionals, but also caregivers and family members of individuals struggling with dementing processes. So the professional advisory board has been taking that on as our special project, and so we've been doing that annually for several years now. Anyway, so that sort of pivoted nicely into being the Alzheimer's dementia champion at Lake Health when the ECHO program became available to our clinicians. I had the opportunity to participate in the first cohort of the ECHO series myself, and after that had been connecting with our health services director, Amy, and she and I talked a lot about how we could kind of codify the educational offerings from the ECHO program and parlay that into quality improvement at my hospital system. And for the past 6 months, I suppose, we've been working on just that. We have been very much appreciating and absorbing the knowledge that has been gained from the ECHO program. The leadership at our hospital system, however, was extremely motivated to see how else we can measure its impact. And so then from there, we were driven to take a look at our current state and see how we could make improvements to our dementia care. And that the project that came out of that is largely what I want to talk to you about today. So early detection is a recurrent theme, and I personally believe that it is the most important theme because you can't do anything until you have a diagnosis. And generally speaking, educating individuals about things that they don't really have any incentive to absorb isn't always that effective. So until you have this in your life and it's a problem for you, you don't necessarily absorb quite as effectively. So I really do think that early detection is the most important thing that we as caregivers, clinicians can focus on. So from there, we kind of backtracked and said, well, how do you get the diagnosis? How does it get detected? And there has to be some kind of a formal cognitive assessment as the very initial jump-off point. Our hospital system, while we have a sophisticated electronic medical record, it does not necessarily, or did not necessarily, have cognitive screening tools embedded in it. And after we did a little deep dive into our data, we identified that we, as a hospital system, as a network of primary care providers, were not doing a very good job of screening for cognitive changes on a routine basis for all individuals of a certain age and older. And so, we kind of climbed into this a little bit, and we were able to identify that the annual wellness visit that is, and let me interrupt myself for just a minute. I understand that the panel of individuals here you guys are not necessarily all medical providers. Is that correct? Okay. So I just don't want to, be condescending or anything, so just bear with me. So the annual, when you're talking about clinicians, you really need to speak to them in terms of how your visits are going to be determined as far as what you're going to focus on, how you're going to document on it, how you're going to code for it, how it's going to get reimbursed for, etc. So, we have to take all these things into account. And what we initially looked at was the Medicare annual wellness visit, which is a comprehensive visit. So it's really like a soup to nuts. Your clinician is looking at every part of you, making sure all of your screenings are done, mammograms, colonoscopies, annual blood work, etc. So it's a real deep dive into a person's whole body holistic health. And the cognitive screening is supposed to be built into this annual Medicare wellness visit. And there's a specific code that's used for it, etc. So we kind of decided we were gonna use this angle because we were not, when I say we, I'm speaking about my practice group at Lake Health. We were not necessarily specifically documenting on the cognitive screening component of our annual wellness visits. Certainly that doesn't mean it wasn't being done. These are primary care providers, remember? So they are connected with these individuals. They've known them for years often. And so many primary care providers would make the argument that, well, my cognitive screen is done during history obtaining, because if the person is speaking to me and they are remembering things that came up months ago and what have you, then I know there's nothing wrong with their cognition. Which, okay, you could make that argument, but that's why we have evidence-based tools, because lots of folks are really good at compensating for their cognitive deficits. And we use evidence-based tools specifically to cut through that, social compensations and what have you. So, we decided to focus on this angle of things. What we ended up doing was embedding the mini cog into our electronic medical record, which is a very simple screening. It essentially consists of 3-word recall combined with a clock drawing test. And so, knowing that in this day and age of medicine, time is certainly of a premium, and our clinicians really do struggle to get everything done that they need to get done in a 15-minute visit. And so asking them to do one more thing is going to be quite a bitter pill to swallow. And so we really wanted to come at this from a user-friendly perspective. How are we going to be able to bring everybody on board and make it seamless and effortless, because it's the right thing to do, so we should make it the easy thing to do. And so we ended up doing this, embedding the minicog, and we've got our trigger is anybody 65 years and older who's coming in for their annual wellness visit is going to have this screening done. It's going to be performed by the nurse or the medical assistant who is rooming the patient. So they'll come in and they'll say, these are these 3 words, and then they'll go on and do the vital signs and check their med lists and make sure their medical history is up to date, and then ask for recall of those 3 words. And as the patient is going into the office to be seen by their provider, they're handed a pre-printed circle and asked to work on their clock. So then they have something to do to work on while they're waiting for their provider to come in and see them for their medical visit. The provider then takes the results of the clock drawing and the 3-word recall and generates a score which they can put into the electronic medical record. This is going to be in a structured data tab such that we will be able to run reports on it, and we will be able to say not only how well we're complying with this regulation, you know, what percentage of times it's actually getting done, but also it'll generate scores for us, so we can have rough ideas of how frequently people are testing with a positive screen. So, so we embedded the cognitive screen into the visit, which is all very valuable, but if nothing is done with it, what good was the effort to embed it, right? So our next step was, how are we going to actually utilize this data? And we decided that the best way to frame this, for a number of different reasons, was to use cognitive health as any other body system. So, for example, if you have a patient who has diabetes and they come into the office and their blood sugars are consistently in the mid to high 200s, you understand that something is not right. It's not an emergency. You don't have to send them to the emergency room right now, but it definitely warrants more follow-up, closer follow-up. Similarly, if you have a patient who comes into the office and they're well-dressed, they're clearly well-nourished, they have a caregiver with them who drove them here or whatever, there is no emergent need for intervention, but they had a positive screen on their cognitive assessment, so something needs to be dived into. And so what we landed at was a positive screen is going to automatically generate a second follow-up visit. So this is an opportunity for the clinician to focus exclusively on the patient's cognition. And the patient will come back in 2 or 3 weeks or whatever the provider thinks is appropriate, and they will do whatever that clinician likes to do for their initial workup of cognitive changes. So anyway, we put together a document here, which I don't know how to do screen sharing on Microsoft Teams, so I don't know. Jen, this is the document that I sent to you, so maybe it's something that you can pull up and you guys can look at, but in any case, essentially, this is evidence-based recommendations on working up cognitive changes. So we've got multiple domains in here: lab work, diagnostic imaging, depression screening, cognitive testing, and advanced care planning. And we put together, I'm a geriatric specialist. This is my blood, sweat, and tears, so it comes very naturally to me, but I recognize that lots of internists who don't necessarily see exclusively a geriatric population may not have the same level of comfort setting up a workup for a potential dementing process. So this is essentially what I would do. And we obviously put the references in there to support why you would do this. Ruling out organic causes for cognitive changes and recommendations for appropriate referrals as needed. So we're in the middle of this process. So we haven't yet rolled out our education for our providers, but what we're essentially going to be doing is giving these resources to all of our providers in the community, in the Lake Health community, and imploring them to utilize these guidelines as a jumping off point for their workup. And go from there. And, I didn't want to go too many layers deep on next steps. I really wanted to get a baseline of information and see where this takes us, because it's very possible that our clinicians are motivated, and once they have this cognitive screening just done for them without them having to say, oh, I should formally screen their cognition, then it might be just enough for them to say, okay, now I know exactly what to do next, and we're going to start having these conversations. And this is going to help to eradicate stigma. If we treat your cognitive changes the same way we would treat any other comorbid condition, then it's going to seem less frightening and less dramatic and just more part of who you are. It's not bad, it's just different. So that's kind of my little corner of the campaign to normalize cognitive health. And that's what we're working on today over here at Lake Health. And I'm excited. We did have one opportunity where our medical director trialed this for about a week in her clinic, and one of the physicians there had, he wasn't involved in all this backstory I've described. He just noticed one day that his patients were being roomed with this cognitive screen, and that he was being provided a mini-cog to address during the visit. And he came out and he was like, "This is great. I never would have caught this guy's cognitive changes had I not had a mini-cog. Would never have thought, oh, I need to do a screening because something's not right with him." And he's like, "Now all I need to do is like XYZ referral, and this is awesome. This is a good thing." And so this gentleman was not paid for this endorsement, but I felt really good because I was like, hopefully this is going to be the same kind of reaction we get from all of our office-based clinicians. Personally, I practice in the house calls arena, so I'm only seeing patients in their home setting. And like I said, most of my patients already have dementia once I get them. I'm not doing a lot of diagnosing myself. I usually inherit them once they're homebound, which is well into the process. So so I'm not intimately aware of how office-based folks are going to be responding to this kind of initiative. So we'll see. But I will keep you guys posted as it unfolds. But it's exciting stuff, and I'm looking forward to having some data to share and being able to say, like, this time last year, our rates were 6% of folks were getting cognitive screens, and now it's 78% or whatever. So it's looking very promising. And that's what we're working on. I'm open to any questions or comments that you guys have, okay?
Yeah. So, Lindsay, I love this. So I don't know, how is this just a Medicare reimbursable thing, or how does that work?
The annual wellness visit, it even has its own initials, the AWV, is a Medicare benefit, yes. However, as you guys are probably aware, Medicare tends to dictate how we structure our visits and how we bill our visits, but Medicare also tends to be pretty spot on when it comes to the appropriate, like the gold standards of care. So even if somebody has a non-Medicare insurance, I'm quite sure that the commercial payers also have a similar reimbursement for such a visit.
Would you
It's very rare that you find somebody who's over 65 who's not on Medicare. It happens, but it's rare. Yeah.
Would you give that acronym again? My sound is really off with, I'm having a little difficulty, so.
Sure. It's Annual Wellness Visit, or AWV.
Got it.
Yeah.
Hey, Lindsay, I with Pam, I think this sounds awesome, and I hope it can be something that's more widespread. What do you anticipate being the follow-up steps for the primary care physicians? I know when I've talked to primary care folks in the past, it's been like, well, even if we notice a difference, there's nothing we can do. So unless it's causing a problem, we sort of don't focus on it, right? So, like, are you expecting neurology consults, or what are you expecting that sort of next step to look like?
So that's actually a really great point, because I will also readily admit that I once believed that saying, you don't do a test unless you're going to do something with the information. I subscribe to that wholly, particularly in the geriatric population where goals of care are the most important thing. And I will say that that's not really true anymore. I mean, when nowadays there are things that can be done for folks who are having cognitive impairment, and it's not a cure per se. It's not a medication that's going to fix or reverse your cognitive changes, but you can connect the family member with support groups. You can get them education so that they can age in place safely and with confidence. There are things that can be done. And honestly, I do feel that statement reflects a certain amount of ignorance on the part of primary care, which I'm not faulting them for. It wasn't part of their training. They are not geriatricians. So that's an education component. So I'm really hoping that out of this is born a newfound confidence and appreciation for the non-medical side of it. you know, I'm a nurse practitioner and I wear that badge proudly because it means I was a nurse before I became a clinician, a provider clinician. And nursing is a holistic art, and you don't just look at the dementing process. You look at the person, and you look at the family, and you look at where they're living and how they're living. And so, you know, the docs are going to need some help to think outside that box a little bit because they've been trained to be experts on the pathophysiology of the body. So, you know, we're going to continue to educate and hopefully slowly but surely kind of eradicate that defeatist thinking.
Yeah.
No, that's great.
Quick question. So, Lindsay, how do you hope to further develop this program? Either just at Lake Health, or do you have any ideas about making this a wider spread program within your region of the state, within the state, or are you really so focused right now on your results in Lake Health that planning hasn't really been started?
Yes. Yes, I certainly have some creative ideas about how I'd like to roll this out to the world. But I'm also kind of mired in the details of this current rollout. So and also in full disclosure, my hospital system is merging currently, like actively, with a much larger hospital system. I'm not sure if you guys are aware, if you're not around here, you probably haven't heard it in the news, but essentially University Hospitals of Cleveland has bought Lake Health. And that was finalized on April 16th. And over the course of the next 6 months, we are going to be acclimating into their network. And it's a large network. And I've been very cautious about making too many plans just because it's extremely unclear how our transition is going to go. And I also am not really aware of what they currently have in place. So I do have every intention of connecting with Foley Elder Health is actually the geriatric practice at university hospitals. And my first step is going to be connecting with them and kind of putting our heads together about what they've been doing surrounding early detection and just in general increasing the conversation and comfort level with managing dementia. And then kind of going from there. I mean, I am so lucky to live in an area that has so many resources. I mean, we've got the Cleveland Clinic and university hospitals that we are now a part of, and that's just so beneficial, I think. You know, there's a lot of invested parties and a lot of resources. So I gotta get a feel for what they're doing before we can take next steps. But, you know, I guess if I could summarize, it would be, you know, a philosophical campaign to bring providers around to not feeling scared of addressing this. Because I think, you know, they will probably deny it, but I think there are probably many providers who are just like, I don't want to get into this hornet's nest because I don't have the time to exercise the sensitivity that is required for these kinds of conversations, and or I was never really taught how to have these kinds of conversations, and or I've never actually lived with a person with dementia, and so I don't actually know what it looks like. So, you know, there's so many variables, you know, and I do think it starts with us as the providers to educate ourselves so that we can boldly and fearlessly guide our patients.
So one of the organizations that we're going to be interviewing is Hospice of the Western Reserve. And while
wonderful.
Yeah, their partnership with university hospitals is focused on the end of life and palliative care, they do bring a really strong commitment to dementia care and dementia, understanding of dementia. So there might be a synergy there for you, even though, you know, it's end of life. Pardon?
Do you know who's going to be speaking with you?
Yes, Jennifer Stone, I think is her name.
Okay. All right. it's a very large institution. So I do know a lot of people over there, and I utilize them quite frequently. They do a wonderful job. Excellent caregivers there. So that's exciting. I'm glad to hear you're going to have an opportunity to speak with them.
Mhm.
Are there any other questions for Lindsay? Lindsay, you've given us fabulous ideas on what we can do
Great.
to, you know, spread forward that early detection in Ohio, in general. Yeah, this is, and it not so complicated, right? It's not that complicated.
Right. My favorite saying these days is, how do you eat an elephant?
One bite
One bite at a time.
Yeah.
It's Jennifer Stone.
Right?
Jennifer Stonebrook was the name, by the way.
Jennifer Stone, okay. I know her name, but I've not met her in person, I don't think. So she may not know me. I'm not very well known. So just a worker bee with a passion, trying to convince people to do the right thing. So
I think
hear your
I
voice.
get to know you soon. Yeah.
All right.
Great.
This has been fabulous. Lindsay,
if
thank you.
anybody has any, feel free to send them along via email. I'm happy to stay in touch if there's any way I can support you in your endeavors.
I'll send Lindsay's contact information out.
Yeah, that'd be great. We may have to contact you again as we move forward.
Feel free. Okay.
All right.
Great. All right.
All right.
So much. Have a great day, everybody.
Thanks, Lindsay.
Bye.
So for the rest of
Bye.
us, that was fabulous. Thank you, Jennifer, for bringing Lindsay on board with us. That was wonderful. That gives us a good idea. If you could roll that out to Ohio providers, right? I mean, what a good early detection for all.
My understanding is, just to follow up to, I think it was Diane's question about, rolling this out further. I believe that there is a hospital system out of the Cincinnati area that has joined the most recent cohort of Project Echo. So they might be on maybe their second session at this point. I'll follow up with Amy, who Lindsay referenced. Amy is the director for hospital systems, I think it is. So I'll check with her and see what other facilities have joined Project Echo to see if there's any traction here in Ohio.
Perfect. Okay, go ahead.
How many years ago did doctors begin asking about, are you safe at home? When you do your annual physical or any doctor's visit. So it's not unheard of to have this sort of very easy question. I mean, it just seems so straightforward to have this done at the time that individual is checking you in and, checking your vitals, to be asking these questions.
Rod went through the exact same thing this week. My husband is, he's on Medicare, so he's 62 and on Medicare because of the diagnosis. And we see a primary care physician with Ohio Health here in Dublin. And they did exactly that same assessment with him. The 3 words, the medical assistant did it as part of the other questions that she had for him. And then he had to draw the clock. And they came back and asked him the 3 words, and Rod remembered, which, for somebody with the diagnosis was a big deal. And so the primary care physician, first thing he walked in, first thing out of his mouth was, can you still give me the 3 words? And, it was wonderful to see that in action. Now Rod and I are obviously well connected with care for him, but our primary care doctor was right on top of it, and it was just fantastic.
Wow, it's a good story. So moving forward, I will contact Melissa this week with this suggestions, and then hopefully she can turn that around for everyone's approval. I will send out the questions that I had prepared for the other providers that Catherine is arranging for the dates and times. And if you have any ideas or suggestions, please send that back. And also, once you get the dates and times, feel free to join. That would be wonderful to have more participants in each one of those. And I think, and then Tessie, you're gonna reach out to the hospital association perhaps, and Beverly, perhaps we can reach out to the first responder or the safety committee.
Yep, both of those emails have already been sent, so we'll let you know when we hear back.
So I feel like we're getting some momentum. Is there anything anyone else has right now? I have one more question, Tessie. Our overall meeting is, our task committee meeting is, I need that date.
24th. Yes, nope, I'm gonna send out the invitation as soon as we're done. I'm still working on the agenda. I was going to just email all the committee chairs, but I can just ask you now, what items do you want on that main task force meeting agenda? I think we're going to try and have everybody all together for the first hour and then reserve time after that to break off into committees so we can do some more work instead of spending the time all together.
I think that we definitely want to have Melissa survey.
Okay.
And talk about that. And maybe, by that, will we have talked to anyone by then, Catherine?
The 21st, I think, is the first one, so we'll have had our first.
We'll have our first. And maybe we can talk a little bit just about that, about doing those.
Okay, so a report out from committee work and then also an overview on the expert interviews.
Or the
Provider.
The provider. And care, yes.
Okay.
And so with that being said, I think we did it. So I call to adjourn.
Seconded.
All right. That's it.
Thanks,
Very
everyone.
good.
Thank you, everyone.
Thank you.
Bye-bye.
Okay.
Bye.
Bye-bye.